Good morning. Welcome to Psychiatry Grand Rounds, and welcome to October. Before Dr. Deutsch gives us a formal introduction of our speaker, Dr. Kennedy, I want to go through my usual housekeeping issues. The microphone seems to be vacillating in its powers. Everybody hear it okay right now for the moment? Let's see how it goes. I don't know of any speaker conflicts, and if there are some, I imagine they'll be on a slide, but usually I get that information, and so I'm assuming there are none. Our sponsors are listed on this slide at the front, and we're very grateful to them for all their assistance for this fall semester of Grand Rounds. This month of October has 5 Thursdays, and we've got a very exciting list, starting now with Dr. Kennedy, and I hope to see you all. There may be off-label or investigational uses of drugs, and this is a disclaimer, even though I doubt strongly that we'll have any such issues. If you are a PhD and you wish to get continuing education credit, you must fill out one of the forms in the back and put your name at the top. The forms are for feedback, and we appreciate feedback from everybody, and we hope that everybody fills out feedback forms all the time. But for the PhDs, you have to do it. And we do cut your name away from the rest of the form, so if you make comments, they won't be attached to your name. Please silence beepers and cell phones. Dr. Deutsch is a professor of psychiatry and pharmacology in our department and has graciously offered to provide an introduction for this talk on the neurobiology of aggression by Dr. Craig Kennedy.
I think we're delighted to welcome Dr. Kennedy to today's Grand Rounds. Dr. Kennedy received his PhD out west, the University of California at Santa Barbara. After he went further west, you can't go further west than the University of Hawaii. He then came east, but not to Nashville, to the Medical College of Pennsylvania, and then was finally drawn to Nashville, although he assures me it was not because of country music. He is an extraordinarily distinguished and well-known scientist and educator and clinician who is currently chairman of the Department of Special Education at Vanderbilt and professor of pediatrics. He is the author of 5 books, about 100 peer-reviewed articles, numerous talks, awards ranging from Best Teacher Award to panels of national prominence. We're delighted to have him and to learn about the neurobiology of aggression.
Thank you very much, Ariel. Let's see, can you hear me on the microphone? Okay. All right, and so I suspect you don't get too many Peabody people coming across the street to give talks. It's always a pleasure to be over on, as we say, this side of the street rather than the other side of the street. And that works. This is a very nice system. Okay, so the outline of my talk today. I'm going to give you an overview of aggression, a general review of definitions, and a little bit of epidemiological information, a little primer on the neural mechanisms of aggression, and then I'm going to take the majority of the time to talk about some of our preclinical animal model work on aggression. All right. The general definition of aggression is overt behavior with the intention of inflicting physical damage on another person. It's a very general and vague definition. It's one of those definitions that has arrived by consensus from a group, so everyone has their component in it. But generally, it takes somebody doing something and meaning to or intentionally harming another person. or another organism. Well, animals should be included in that. But it doesn't necessarily take into account some of the other forms of aggression, such as passive aggression, when somebody omits responding to have a negative effect on somebody else. Or what we see more and more in popular media and some research on social aggression, particularly among adolescent girls. Sending a nasty text message to a friend that says, "Randolph is now my boyfriend," doesn't necessarily mean to be inflicting physical damage on somebody, but clearly it's a hostile act, particularly if you're 14 years old and you both want to date Randall. So it's a vague definition, and it applies in some instances, but I'll give you some examples of instances when it doesn't. And I think in general what we do is we look at it in terms of clinically, you know it when you see it. It's one of those phenomena, it's a social construct. We try to wrap language around it so it makes sense, but we know what aggression is when we see it occurring, even though it's hard to define. Generally in the literature there are two forms of aggression. There's a third, defensive aggression, but I'll just review premeditated aggression and impulsive aggression. Premeditated aggression are planned acts of aggression, also referred to as predatory, instrumental, or proactive. The general notion there is that it's a planned out act to injure or harm another person, whereas impulsive aggression are exaggerated responses to what should be normal emotional situations. And there's been a lot of work recently in this area of impulsive aggression around ethanol or alcohol escalated aggression, and how alcohol actually, in animal models, escalate aggression. And kind of getting back to the vagaries of definitional issues around aggression, I'm going to talk about rodent models of aggression and some of our work, and it's generally referred to as impulsive aggression. However, a lot of the data I'm going to present today actually has instrumental responses built into it for the mice to earn access to aggression. So whether it is premeditated on the mouse's part or impulsive, I'll let you all decide. But the definitions are not that firm. And let me give you an example from my own clinical area. I've been working for the last 25 years with people with what we call intellectual and developmental disabilities. I think pervasive developmental disorders would capture a psychiatric definition. People with severe intellectual disabilities, mental retardation, adaptive behavior below the age of 5, and syndromes like autism, Down syndrome, Turner syndrome, Angelman syndrome, and so on. And mainly because of my early experiences getting beat up when I was a teenager working with this population, I became very interested in aggression. Thought, well, instead of going to work and getting beat up every day, why don't I understand why I'm getting beat up, and maybe we can do something about it. And here's not an unusual example of an individual who has an intellectual disability, IQ below 30, not verbal, a few gestural signs maybe. They engage in self-injury and aggression. One of the things we've learned in this population over the last 20 years is that most of the aggression and self-injury, property destruction we see in this group is a form of communication. Because of a very limited verbal repertoire and perhaps conceptual understanding of how to communicate, what we see is self-injury and aggression in this group often gets shaped up by caregiver interactions. People get ignored, then they hit themselves, someone comes over and provides attention, the person enjoys attention, they have no other way of obtaining attention, so they hit themselves again, they get attention, and it gets shaped up over time. And so it's not unusual to see somebody engage in a self-injurious response, such as hitting themselves in the face and grabbing or pinching another person, and have it serve the same instrumental or operant purpose, such as being positively reinforced by attention from an adult. Now, is that premeditated? The person's doing that for an instrumental reason, or is it impulsive? Well, it gets even more complex. A lot of our research has shown that people with intellectual developmental disabilities and severe behavior problems also have a twofold increase in special health care needs: GERD, constipation, migraines, sleep problems, asthma, allergies, things that often don't get diagnosed by primary care providers or pediatricians, but that seem to exacerbate the self-injury, particularly since people are experiencing pain and making situations more noxious and aversive to them. And maybe the presence of the mother escalates the aggression, so that when the person has just had a meal, they're in pain, they're more likely to want to get attention. Their mother walks in the room, and immediately they start self-injuring and aggressing. It's hard to know whether that's premeditated or impulsive or both. And so that's my little spiel, if you will, on the vagaries of defining aggression. We know it when we see it, and we're at our best when we're experimentally analyzing why it is occurring. In terms of epidemiology, this will be familiar, I think, to most of you. According to the 2002 white paper by the World Health Organization, 1.6 million deaths per year from violence. Violence is the leading cause of death among 15 to 44-year-olds. For people with mental disorders and substance abuse, approximately 44% will engage in a violent activity during their lifetime, and even without the substance abuse, 35% of the people we work with will engage in some type of violent event. Among adults with intellectual developmental disabilities, 17% of that population have persistent and very difficult to treat aggression. Aggression that often is very, very expensive to treat. The last cost estimate that was done is way back in 1944, and it estimated $4 billion a year were spent in the United States to treat the aggression of adults with intellectual disabilities. I know in Tennessee, in individual cases, we spend anywhere from $100,000 to $250,000 a year treating individuals with these conditions. And interestingly enough, I've had quite a few venture capitalist firms contact me in the last couple of years who are interested in investing in businesses that provide residential services to kids with autism who are aggressive and the like, because of the amount of money involved in it. It's actually quite a growth area at the moment. Now, there's some interesting societal and species contradictions in aggression. Aggression's highly conserved across species. We have yet to come across violent sponges, but we do see mean lobsters and aggressive flies. Ed Kravitz at Harvard does a lot of work with lobsters and serotonergic circuitry and aggression, and if you go and you type in Edward Kravitz, you get some wonderful videos of mean male adolescent lobsters going at it. But also, it's hard to think of a mammalian species that doesn't engage in aggression. And that's probably because it's a highly adaptive set of behaviors. You engage in aggression, whether you're a mouse, non-human primate, or a human, perhaps, to defend territory, to gain access to a mate, gain access or defend food resources. If you're not aggressive, you're at very much a negative disposition in procreating and just surviving over time. So it's not surprising that mammals have been selected over time to be aggressive. And humans, apparently, a lot of the genes and neural circuitry involved in aggression are conserved in human beings, so we're probably predisposed to being aggressive in ways we wouldn't like to be as a society. And perhaps because of that, human societies come up with ways of sanctioning aggression, at least in my perspective, that allow us to observe and engage in aggression in ways that we consider socially appropriate. So we can go and watch boxing matches, we can play rugby, we can do various things that seem to be involved in aggression and that it looks like we enjoy. So it appears that in humans, we enjoy aggression. I'll talk about that a little bit more in a few minutes when I show you some information from a fMRI study, our first little venture into fMRI about that. We'll show you some mouse data as well. All right, there's two general models of aggression in the rodent literature, preclinical literature, maternal aggression and the resident intruder paradigm. And the resident intruder paradigm, because of its ease of use, has become the standard for doing preclinical work, particularly with mice and rats, around the neurobiology of aggression. And it looks a little bit like this. Or not. Actually, we've had a mutant mouse type called a TLX or tailless gene knockout mouse They're a little bit smaller than that, but they're actually a rather mean beast, and they probably could take out that cat. They've taken down a few Division of Animal Care workers over the years. But the resident intruder model, you pair a male mouse, which we define as the resident, with a female mouse after 28 days. And you group house a group of males that we label as intruder mice. After about 60 days in the resident cage, we test by removing the female and any pups that are present. We introduce the intruder mouse, and we observe for about 10 minutes the species typical forms of aggression in mice, which are they rattle their tail and they turn sideways, and then after a couple of seconds they lunge and start biting and boxing the intruder mouse. And it's a very easy replicable model and has proven very amenable to experimental analyses. Now, here's a recent paper by Randy Nelson and one of his colleagues, an image from that paper in Nature Reviews Neuroscience that shows some of the anatomical loci of aggression. In the prefrontal cortex, it's associated with decreased aggression. There's an inhibitory function, if you'll allow me to say that mice have prefrontal cortices. They have something up front in their cortex. And it inhibits aggression. But there are also some structures, often stemming from the olfactory bulb, involved in the initiation and continuation of aggression: lateral septum, the BNST, hypothalamus, amygdala, and then the paraqueductal gray area is involved in the initiation and continuation of aggression. Now, in terms of neurotransmitters associated with that, I'm going to talk a little bit about serotonin and dopamine today, the monoamines involved in most likely in aggression. I'm not going to talk about neuropeptides or neuroendocrinology, but it does get very, very complex and wonderfully so. But I'm going to give you just a real primer on this. Serotonin in the prefrontal cortex primarily serves an inhibitory function on aggression in rodent models, as well as a lot of human clinical data. Whereas dopamine in the ventral striatum, primarily in the nucleus accumbens, serves an excitatory role. And I'm going to present some of our data and Klaus Mitschek's data on that. Real quickly, evidence for serotonin being involved in the inhibition of aggression includes data on this. I'm drawing primarily from animal model studies, but there are also quite a few human studies, and the human studies in particular have had very variable results, but even animal model studies have variable results around serotonin and aggression. But generally, lowered levels of 5-HT are associated with impulsiveness and aggression. So you can lesion the raphe nuclei, the dorsal raphe, median raphe. You can disrupt the biosynthesis of serotonin in the cell by providing PCPA. You can generate knockout animals that lack a 5-HT1A or 1B receptor. They all become aggressive. And in the case of, for example, the PCPA disrupted biosynthesis, if you deliver 5-HTP, you'll reverse that aggressive effect. Or if you deliver 5-HTP, which facilitates the biosynthesis of serotonin, you'll actually decrease the probability of seeing any aggression at all. Other ways of increasing serotonergic tone, if you will, the delivery of SSRIs, or receptor agonists for 1A and 1B serotonin receptors, such as 8-hydroxy-DPAT, all inhibit or decrease aggression when you would normally see it. So serotonin seems to have a modulatory effect on aggression. Dopamine, if you antagonize dopamine receptors, D1 and D2-like receptors, and you provide it through, which has been the standard way of studying dopamine function in animal models, systemic injections decrease aggression, but they also decrease all other types of behavior, which is more than a little confound. There was a lot of excitement in the early 90s about the possibility that dopaminergic antagonists could be used to treat aggression, and it was done through animal models. And the initial enthusiasm for those findings was tempered when additional investigations were conducted, and they measured more than aggression. They measured general movement, grooming, which turned out to be absent. So the animals kind of just became cataplexic, and were not aggressive, of course. And so for about the last 15 years, there's been a general confound in understanding dopamine's role in aggression, mainly because of lack of animal models to study its role in particular nuclei in the brain. Let's see. More recently, though, people have been doing more direct and localized analyses of dopamine and serotonin. This is a mouse model using the resident intruder paradigm. This is from my colleague Klaus Mitchak at Tufts University. And this is using microdialysis as a technique to study extracellular levels of serotonin and dopamine here in the prefrontal cortex. And what you have is a baseline in which you have the resident animal in their cage, no other animal present. You introduce the intruder animal. You allow them to have a 10-minute bout of fighting. You remove the animal. And what you see is during the fight, you get statistically significant decreases in serotonin in the prefrontal cortex. And then after the encounter, those decreases in serotonin maintain for over an hour, whereas dopamine continues to rise after the encounter. Now, these are unsignaled studies, so the animal simply dropped in. It's not a situation where the animal can predict that there's going to be an aggressive encounter. Here's some information from the same study on the nucleus accumbens, in which what you see is a non-statistically significant increase in serotonin, but a very substantial increase in the accumbens in dopamine following the encounter. And interestingly, if you provide a signal to the animal so that it knows that in 5 or 10 minutes there's going to be an aggressive encounter, it's a signaled reward, if you will, what you get is before the aggressive encounter, when the signal is presented, you get a significant increase in dopamine levels in the nucleus accumbens, which is very consistent with what you would see in drug addiction or other types of reward paradigms. So it suggests, these data suggest that being aggressive is rewarding in mice. And so what we did, being operant psychologists, we came up with a Skinner box, if you will, in which the mouse has to work to earn the access to aggression. So we took the resident intruder paradigm and put in an instrument panel in which the animal had to nose poke a certain number of times or in a certain pattern of behavior. We would then, once it met the response requirement, we would introduce the stimulus mouse. And that is a positive reinforcement paradigm. It's the type of paradigm that you see instrumental responses being maintained by drugs of addiction, sex, water, any stimulus that'll function as a positive reinforcer. And the question was, well, is aggression a positive reinforcer? Will mice actually work to earn being aggressive? And Michael May in my laboratory just finished his dissertation on that. He's now at Southern Illinois University. He did a long series of analyses, only an operant psychologist could get excited about these, in which he took individual mice, established baselines, in this case, this particular graph, a variable ratio 10 schedule of reinforcement, meaning the animal had to nose poke on average 10 times to earn access to aggressive bout. He also did things like made the animal have to engage in pace responding or in very fast bursts of responding, a number of different types of instrumental responses to show that, in fact, mice will work very hard. So he established this reinforcer arrangement. The animal would nose poke on a regular basis to earn access to aggression. He then put it on extinction by not introducing the stimulus mouse, and the mice decreased or stopped their nose poking. And then when he reintroduced that contingency, where he dropped the mouse back in, they would go right back to nose poking. That's a very classic demonstration of something as a positive reinforcer. So in mice, it certainly looks like, from an instrumental standpoint, aggression is a positive reinforcer. Another student of mine, Maria Kupas, who Ariel was on the doctoral committee of, recently published some findings where what we did is we took mice in this instrumental paradigm and cantilated them so that we could provide microinfusions into the nucleus accumbens of the animals, so that we could get past the problems of systemic administration of dopamine antagonists causing inhibition and movement, and instead go in and just antagonize dopamine receptors in the nucleus accumbens, or at least, and that's actually what we were able to do. And this panel on the left-hand side are data from the canal placements that were accurate. They were inside the nucleus accumbens. And on the right-hand panel are data from animals in which we missed our target. So you can think of this as control animals. And we used D1 and D2-like receptor antagonists. And what we got were, we have nose pokes per minute, meaning operant responses to get aggression. And we measured movement also. This is the movement, this is the aggression, and what we did is we got significant reductions in aggression without disrupting movement with these dopamine antagonists, suggesting that the neural circuitry, the reward pathway, if you will, that we see working with other events that function as positive reinforcers are also acting in aggression. So it looks like, okay, aggression is rewarding, it involves the reward pathway, and dopamine's involved. There's very large literature, human and non-human, on the reward pathway. And so what we decided, since in fact I'm originally a clinician and that's probably what I do best, is let's work with humans and see if we can replicate our mouse model with people. And we're fairly fearless in taking on new paradigms, which hopefully one day I'll learn not to do this. I'd be better off just learning one technique and using it over and over again. We decided we would try fMRI. John Gore's group is here, the Imaging Institute, and we thought, well, since they're just across the street, quite literally on 21st Avenue, let's try our hand at an imaging study. So when I was asked to do this talk back in June, I thought, well, we've just initiated those studies. I'll have lots of data to show, and I'll be able to show a group of psychiatrists my first imaging data. Well, I was hoping to be able to say, this is what your brain looks like on aggression. But we're still learning how to image people and get through sessions without them crashing. And once that is done, we're going to have to learn how to analyze the data. So we are learning how to do fMRI studies, but we have no data yet. And I have a new appreciation for people who do fMRI studies. It often sounds like you just pop people in the scanner and out come the data. And it's always that way until you actually try a new experimental paradigm. So instead, I'll present some other human data. We've been interested in the last few years in the monoamine oxidase A promoter gene. In mouse models, the MAOA gene, if you knock that gene out, the promoter gene out, it produces a highly aggressive phenotype. This has been known for quite a while. It matches on nicely with a study by Bruner and colleagues from '92 in Science, in which they came across a family with that were essentially mutant for the MAOA gene and had this long family history of aggression and violence and bizarre, impulsive behavior. Humans possess kind of nicely two general variants of this polymorphism. One's a low efficiency and one's a high efficiency genotype. So it's very easy to classify, and it's nice when things come out in the world in a binomial manner. I guess at this point, a fairly famous study by Caspi in 2002 in Science showed that adults in New Zealand who had been tracked from youth into young adulthood, and they had the DNA from these people, they had repeated psychological assessments, and they had access to criminal records, and the N was somewhere between 800 and 1,000. So it's one of these amazing dream samples that you have that Terry Moffat, one of the co-investigators on that study, had collected. And when they did an analysis of the genotype-phenotype, what they found is that people that had been exposed to violence as youth, physical or psychological violence, and had the low efficiency MAOA promoter gene, were 7 times more likely as young adults to have been arrested for violent events. So they show this very interesting gene by environment interaction, which is proving to be fairly robust in that gene environment interaction. What's less robust is simply looking at the genotype and seeing an aggressive phenotype. It suggests that for the MAOA gene to be involved in an aggressive phenotype, it takes some type of adverse stressor in the environment. But what we did is we started out by looking at a group of people with intellectual developmental disabilities, since that's our population of interest. And we did a sampling strategy that was kind of interesting. This is a low incidence population. At its largest, it's 1% of the general population. And about 17% of that 1% show aggression of some degree. But it's very hard to get access to this population. You have to get state approval, then you have to get departmental retardation services approval, then you have to get care provider approval, then you have to get residential program approval, and then you have to get assent from an aggressive person. And so it is not easy to get a large sample. So we adopted a strategy of, well, we know in this population aggression occurs on a continuum. It's not a binomial variable. And so why don't we sample people at the ends of the continuum? Let's look at people that are very passive and people that have long, long histories of being aggressive. And maybe that'll help us in a smaller end identify the potential for there being an association with the MAOA gene and aggression. And so what we did is we went out and genotyped 35 people who had well-documented two-decade-long histories of being aggressive, and people who had equally well-documented histories of not being aggressive, and took a DNA sample. One of the nice things about this population is because of their intellectual disabilities and state legal requirements, they have to have people present documenting levels of problem behavior, whether they're aggressive or not, 24 hours a day, 7 days a week. So there's this beautiful behavioral history that we can tap into, which is relatively believable data. I mean, the people who are collecting these data admittedly have chosen not to work at McDonald's and instead are working in group homes for $8 an hour, but they are supervised by people who are trained behavior analysts. And so the behavioral data are fairly believable. What we saw in that sample is for the people with intellectual developmental disabilities and problem behavior, we had a sample of 35, and 57% of that group had the long version in this particular case, or the high efficiency MAOA VNTR. And 43% had the short or low efficiency version. For the group with no problem behavior, we saw an 80%, 20% split, which is a slight underrepresentation of what should be occurring in the population. It should be at 33%. But we saw an exact same proportion in our control group, and the control group was just adult males, and the sample in this case were males because the MAOA gene's on the X chromosome, and it shows ethnic variation, so the sample was just of Caucasians. But we found an initial association of this study. We're currently doing some follow-up studies on that, looking at gene-environment interactions, and the environmental variable that we're looking at is the presence of health conditions as stressors. Because we, in some of our other research, have shown a strong association between health conditions and problem behaviors in people with IDD, we think that there may be a stressor by gene interaction that hopefully will result in a 7-fold increase in people with those gene environment characteristics like the CASP study, but I'll report that back to you later. And since we are at Vanderbilt, I have to present a little bit of CERT data. We also genotyped those samples. This actually may have been a different sample. Same approach of intellectual developmental disabilities and problem behavior, no problem behavior, and a contrast group. And the long and short of it is we found no association between the serotonin transporter gene, polymorphic, at least the 5-HTT-LPR, and aggression. But one of the things we're also interested in are their gene-gene interactions. Okay. So I'll just conclude at this point by saying that aggression is rewarding. We know it. We have direct neurobiological evidence in mice. We are waiting for some indirect neurobiological evidence in humans. The dopamine and the reward pathway are implicated in the occurrences of aggression, and monoamine oxidase A promoter gene alleles seem associated with aggression for our research and others. So, are there any questions?
Are there other candidate genes you're thinking about that if you
There
were
are-
to
there
do
are-
a $5 million study that you would include?
You know, vasopressin would come up as something that might be associated with the 1A and 1B receptors. Increased aggression, reciprocal of that, oxytocin may be something associated with lower levels of aggression. Those are neuropeptides. If you look in neuroendocrinology, things like testosterone and so on don't themselves seem to be primary variables associated with aggression. What they are moderators of aggression. In instances in which aggression would typically occur, increased levels of testosterone often are associated with increased levels, but they don't themselves induce aggression otherwise. And then I would come back to monoamines, and I would say COMT might be involved if you look at them. And I'm using a candidate gene approach to this, where I'm looking at mouse models that have been associated with aggression. Serotonin 1A and 1B receptor polymorphisms and 2 receptors are what we're interested in. Something that really hasn't been studied in the aggression literature at all is norepinephrine and its role in aggression.
Question, are you using a reward task in your fMRI study, like Iowa Gambling task?
Well, what we're doing in that study is we're having subjects watch violent sporting episodes, so normal sporting events in which people start beating each other up. Then we're contrasting that with a positively valent stimulus, which turns out to be scantily clad women walking down a walkway. And then we're contrasting that with a negatively valence task, or at least what we hope is a negatively valence task, which is watching a computer assembly task. Now, I'll say this, the first subject we ran on that study liked the computer assembly task much better. But he was a neuroscience student, so apparently we've got some kind of strange sampling bias involved.
Can you tell us about the tailless mouse that you...
Yeah, I was going to present some data on that. We've got some papers under review on that. The tailless mouse actually has a tail. The TLX gene, if I can remember this correctly, is involved in progenitor cell development and migration, and has its primary onset around embryonic day 9.5 in mice. And what you end up with is a grossly underdeveloped cortex. Originally, it was reported in a paper in Nature by Paula Monaghan and colleagues that it was just in the limbic system, which got people really excited. Turns out it's more of a gross anatomical effect on intermediate layers of the cortex. Those mice are just phenomenal. They have some sensory damage that's associated with the TLX gene. If you knock out the TLX gene, you disrupt retinal development, so you get the animals are effectively blind. There's some olfactory impairment as well, and both of those are involved in aggressive phenotypes in mice. The TLX mice, up until what we've done recently, only the mutants had been assessed for an aggressive phenotype, and they're extraordinarily aggressive. You cannot house them with another animal, and in fact, you get an incredible mortality rate of the mice because the dams reject them after about 7 days because the pups are actually attacking the dam. And you can go on and on with these mice. If you try to mate homozygous mice, they eat each other. One will eat the other, and usually they have this very bizarre topography of attacking the other. They end up eating the brain and the genitals of the other animal. I mean, we jokingly refer to them as the Hannibal Lecter mice. And the genotyping these animals is very simple. When they're about 10 days old, you just stick your finger in the cage, and the ones that come out attached to your finger are the mutants. What's that?
Are
We've just got some, the initial data on them that's under review, and they show an intermediate phenotype of aggression. Not quite as severe, but still much higher than the wild-type background strain that they're on, which generally shows no aggression at all.
I had a thought about your comment on dopamine and norepinephrine. It might be helpful to infuse or otherwise inject methylphenidate then versus amphetamine. Methylphenidate will relatively selectively increase dopamine, and amphetamines have effect on both dopamine and norepinephrine, so it
Oh,
might
okay.
enable a differentiation.
Very good, very good.
Talked about the difference between low and high efficiency MAOA genotypes in terms of future aggression in people. Do you know if there's been any functional or structural neuroanatomical correlates with MAOA, high and low efficiency? Has anything been identified there?
There have been some mouse studies done, and to date they haven't found any gross anatomical abnormalities. I don't know that any finer grain studies have been done yet.
What does that mean from a neurochemical point of view in terms of what the changes? There's a different metabolization of the catecholamines out there.
Catecholamines, serotonin, dopamine, norepinephrine, it should disrupt their intracellular metabolism. Jenny?
I'm curious about individual differences in the mice. So the nose sequence task, were all the mice finding aggression to be rewarding, or were there gender differences or other individual differences?
Yeah, I didn't say, we only use male mice because of the resident intruder. It takes advantage of the territorial mate aggression aspect. But we originally did this by using Ensure, a liquid that mice and humans seem to like, because we thought, well, we'll do the kind of classical Fred Skinner thing where you reinforce with food to do the instrumental response, and then we'll switch over to aggression. And what we found really quickly is we can shape animals up just by giving them access to aggression, and they shape up just as fast as they do with food. And I think 95% of the animals we do this with shape up very quickly. So it's fairly robust among male mice, at least. But there's huge strain differences in mice with aggression. And some data I didn't show, Maria Kupis, as part of her doctoral work here, took a strain of mice that was very passive and a highly aggressive strain, and with Greg Stanwood, I saw Greg somewhere come in, we did some radioautography. Never mind, charging into a technique I know nothing about. And found a much higher level of dopamine receptors in the nucleus accumbens of the aggressive mice versus the passive mice. But the mice show huge strain differences, so there are a lot of individual differences in that sense. In the back?
Could you say something about the serotonin 5-HT2A receptor role? Because the atypical antipsychotics, which are very potent antagonists, have been very useful clinically in dealing with the most aggressive psychotic patients.
My familiarity with the serotonin 2A receptor antagonist has actually been in a study that we recently completed with the TLX mice. We originally used clozapine with them simply because we didn't know whether you could get a pharmacological control over the aggressive phenotype of a mouse like that. Turns out we could without getting disruptions in movement. So we did some antagonism and agonism studies with two receptors in general, and got decreases in aggression with those animals. And that's consistent with some of Klaus Mitschek's and Randy Nelson's data on two receptors. And found a lower dosage was effective in the TLX mice, in the mutant mice versus the heterozygous mice.
Craig, could you sort of put your clinical hat back on and say something about stigma of people with mental illness? In other words, there's a stereotype that people with mental illness are more likely, are violent. They're likely to be crazy and do violent things. And the anti-stigma people like to poo-poo that. They like to say, oh, mentally ill people are no more violent than anybody else, and that's simply a stereotype. But your data seems to suggest, and I wonder if your own experience is, that it is true that mentally ill people are violent, more than an average person.
Well, if you look at that World Health Organization data, the epidemiology data that I noted very quickly, there's a much higher proportion of violence in people that are diagnosed with a mental disorder than in the general population. It is a stigma. I know in the population that I work with, IDD, people who have those aggressive behaviors, it's stigmatizing, but it also has profoundly negative impact on their quality of life because their ability to go out in the community, their ability to interact with other people, their ability to do just about any work in a job is greatly reduced because they will attack themselves or other people in numerous situations, and it's not something that can be ignored. And behavioral interventions are generally effective. Pharmacological interventions are sometimes effective with the population. We'd love to work with people to see what the combination would do, but there is definitely a stigma.
Just to piggyback on that, so you said that aggression is very rewarding and is associated with health concerns and presence of mother and other things. And so when you do behavioral interventions, how reduced can you get the aggression? And so is it purely that it's rewarding, or is there something else that would just increase the baseline?
If we can get a handle on diagnosing and dealing with the health conditions that might exacerbate the behavior problems, in about 80% of the cases, in the cases where it's clearly a communication issue, we can reduce behavior levels down from maybe several hundred occurrences per week down to 1 or 2, and we can maintain that over time. The problem is it takes very intensive 24-hour, 7-a-day intervention with skilled interventionists to do that. I don't want to take too long, but I'll give you one clinical example. When I was at the University of Oregon, we did this model deinstitutionalization program. We took people with profound mental retardation and some of the most amazing self-injury and aggressive responses imaginable. And there was one guy that we worked with who, he was just left alone in the institution in a corner. First time I met him, he was laying in his feces and urine, and I said, well, why is this guy laying in his feces and urine in the corner? He said, go over and say hello to him. So I walked over and said hi, and the guy started just pounding on his face. He would do that anytime any human being got near him. So anytime anyone had to interact with him, bathe him, feed him, and so on, he had to wear a football helmet. And he had this upper body that looked like a weightlifter, and it was just from hitting himself. And we got him to a point where we worked with him 24/7, just with the helmet on, and then we slowly would take it off, feed him ice cream, kind of desensitize him, get him used to being off of that, and have behavioral interventions in place. And we got him to a point where he was going 3 or 4 days at a time without any self-injury at all. And he would actually interact with people. And then one day, somebody put the intervention in the wrong way, and it just all came right back. So the success with this population, the IDD population, could be dramatic, but it's extremely fragile and expensive.
So it sounds like what you're describing is akin to extinction therapy, and I'm wondering if, and this may be a fairly new approach in these types of people, but I'm wondering if anybody has considered doing something like what Mike Davis is doing in the realm of phobias with giving things like cycloserine to pharmacologically enhance extinction therapy, if that's one of the kind of core things that seems to be effective in treating this population.
Yeah, I don't know of any studies like that going on right now, and if they were going on, I would probably know about them. Yeah. All right, well, thank you very much, everyone.